Today's topic is thyrotoxicosis. Welcome to our channel Internal Medicine Made Easy, the online learning platform that provides medical education to healthcare professionals and students to improve their clinical skill and help them in their studies, courses, careers, and research. Thyrotoxicosis is a clinical state of inappropriately high levels of circulating thyroid hormones in the body from any cause. In medical study and clinical research, it is often incorrectly used interchangeably with hyperthyroidism, which is a form of thyrotoxicosis caused by excessive endogenous thyroid hormone production. The differential for thyrotoxicosis is broad and will need a combination of a thorough physical exam, laboratory studies, and imaging to determine the underlying etiology for appropriate treatment. Etiology: increased endogenous secretion of thyroid hormone like Graves' disease, toxic multinodular goiter, toxic adenoma, TSH-producing adenoma or pituitary adenoma, HCG-mediated hyperthyroidism, thyroiditis, and drug-induced. Increased exogenous secretion of thyroid hormone, which occurs in factitious hyperthyroidism, and excessive replacement therapy with levothyroxine. The most common cause of thyrotoxicosis is Graves' disease, followed by toxic multinodular goiter and toxic adenoma. Graves' disease is an autoimmune disorder in which thyroid-stimulating immunoglobulin binds to and stimulates the thyroid-stimulating hormone receptor on the thyroid cell membrane, resulting in excessive synthesis and secretion of thyroid hormone. Patients with Graves' disease usually have diffuse, non-tender, symmetrical enlargement of the thyroid gland. Ophthalmopathy, consisting of protrusion of the eyes with periorbital soft tissue swelling and inflammation, and inflammatory changes in the extraocular muscles, resulting in diplopia and muscle imbalance, is clinically evident in 30% of patients with Graves' disease. Multinodular goiter is the result of aberrant growth of thyroid follicular cells following chronic TSH stimulation, which via hyperplasia leads to the nodular degeneration of thyroid tissue. Within a multinodular goiter, the development of hyperfunctioning nodules in the absence of an autoimmune stimulus, as is the case with diffuse toxic goiter, determines the clinical picture of toxic multinodular goiter. Toxic adenoma. A toxic adenoma is an autonomously functioning thyroid nodule that produces supraphysiological amounts of T4 and or T3, resulting in suppression of serum TSH. The function of the surrounding normal thyroid tissue is often but not always suppressed. TSH-secreting adenomas account for less than 2% of all pituitary adenomas and are a rare cause of thyrotoxicosis. It is a syndrome of inappropriate TSH secretion, defined by normal or elevated TSH levels in combination with increased T4 and T3 levels. Gestational transient thyrotoxicosis of non-autoimmune origin is caused by stimulation of the TSH receptor through HCG, which is similar in structure to TSH and binds the TSH receptor. It occurs in about 1.4% of pregnant women and generally occurs in the first trimester of pregnancy, mostly when HCG levels are above 70 to 80,000 international unit per liter. In thyroiditis, thyrotoxicosis is caused by the release of preformed thyroid hormone into the circulation as inflammation destroys thyroid follicles. This causes transient thyrotoxicosis that most often self-resolves. Inflammation can be precipitated by a variety of insults to the thyroid gland, including autoimmune, infectious, chemical, or mechanical insults. Iodine-induced thyrotoxicosis. An excess of iodine through dietary intake, drugs, or other iodine-containing compounds can lead to thyrotoxicosis through increased thyroid hormone synthesis in the presence of underlying thyroid disease, particularly multinodular goiters that contain zones of autonomy. Factitious thyrotoxicosis is due to the voluntary or involuntary intake of supraphysiological amounts of exogenous thyroid hormone. Most commonly, it is iatrogenic, either intentionally in order to suppress TSH in thyroid cancer patients, or unintentionally in patients treated for primary hypothyroidism. In both instances, subclinical thyrotoxicosis is more common. Clinical features. The clinical manifestations of thyrotoxicosis can be diverse, as thyroid hormones can have an impact on a variety of systemic symptoms. The cellular effects of T3 binding to alpha and beta receptors increases thermogenesis and basal metabolic rates. This can result in constitutional symptoms of weight loss, fatigue, and heat intolerance. Skin changes can occur, including warm, moist skin with thinning of hair and pretibial myxedema and Graves' disease. Musculoskeletal manifestations include weakness, increased bone resorption, osteoporosis, and increased risk of fracture. Patients can develop lymphadenopathy, gynecomastia in men, or oligomenorrhea in women. Gastrointestinal manifestations include dysphagia, hyperdefecation, and hunger. Ophthalmologic findings include lid retraction and infiltrative Graves' ophthalmopathy, can be seen in patients with Graves' disease. Cardiovascular manifestations. The most common cardiovascular manifestations of hyperthyroidism are hypertension and tachycardia. Atrial fibrillation and congestive heart failure can occur as well. Older age, higher T4 levels, male gender, and toxic nodules are associated with the risk of atrial fibrillation. There is evidence that subclinical hyperthyroidism can increase the risk of cardiovascular events, yet it has not necessarily been proven to be associated with hypertension. Investigations. Overt hyperthyroidism is confirmed with measurement of serum TSH level, which is usually undetectable because of negative feedback of thyroid hormones on the anterior pituitary. A normal serum TSH nearly always excludes thyrotoxicosis, except in rare cases of TSH-secreting pituitary adenomas or syndromes of thyroid hormone resistance. Free T4 concentration are usually elevated in overt hyperthyroidism. If the TSH is suppressed and the free T4 is normal, serum-free triiodothyronine concentrations should be measured to assess for T3 toxicosis, which may represent the earliest stage of hyperthyroidism. Subclinical thyrotoxicosis is defined as the presence of a persistently low serum concentrations of TSH with normal free T3 and T4 concentrations. Once thyrotoxicosis has been identified by laboratory values, the thyroid radioiodine uptake and scan may be used to help distinguish the underlying etiology. Thyroid radioiodine uptake is raised in Graves' disease. It may be normal or raised in patients with a toxic multinodular goiter. It is very low or undetectable in thyrotoxicosis resulting from exogenous administration of thyroid hormone or from the thyrotoxic phase of thyroiditis. A scan may be helpful in differentiating between Graves' disease and toxic multinodular goiter. The presence of raised serum concentrations of thyroperoxidase antibodies indicates an autoimmune thyroid disorder. A raised thyroid-stimulating immunoglobulin value indicates Graves' disease. In subacute thyroiditis, inflammatory markers such as erythrocyte sedimentation rate and C-reactive protein are frequently increased. In pregnancy, either free T3 and T4 or the total T3 and T4 with adjusted reference range 1.5 times the non-pregnant range should be used for diagnosis in addition to serum TSH levels. In suspected factitious hyperthyroidism, thyroglobulin levels are decreased due to the suppression by exogenous thyroid hormone ingestion. Management. Beta-blocking agents are useful for symptom control, especially in older patients and those with cardiovascular disease. Propranolol is often prescribed, but longer-acting agents like atenolol may result in improved compliance. Oral calcium channel blockers like verapamil and diltiazem may also be used to reduce the pulse rate of patients who cannot tolerate beta blockers. The main therapeutic options are antithyroid drugs, radioactive iodine, and surgery. Antithyroid drugs. Thiamine drugs include carbimazole, methimazole, and propylthiouracil. Their mode of action inhibits organification of iodide and coupling of iodothyronins, blocking thyroid hormone synthesis. Large doses of PTU also decrease the peripheral conversion of T4 to the active hormone T3. Important side effects include agranulocytosis and hepatotoxicity. Thiamides are useful in patients with Graves' disease in the hope of inducing a remission. Because toxic nodular goiter rarely, if ever, goes into remission, thiamides may be used for the short-term treatment of patients with toxic multinodular goiter to induce euthyroidism before definitive treatment, but are not appropriate for long-term therapy. Thiamides are never appropriate for the treatment of patients with thyroiditis in whom no excess synthesis of thyroid hormone occurs. Radioiodine therapy is the most common therapy used for adults with Graves' disease. It can also be used for toxic nodules and toxic multinodular goiters. Radioactive iodine is given in one oral dose. It is absorbed by the thyroid gland, including tissue-specific inflammation that leads to thyroid fibrosis and destruction of thyroid tissue over the next several months. Hyperthyroidism usually occurs within 6 to 12 months. Most patients go on to require lifelong levothyroxine treatment. There is a small risk of thyrotoxicosis exacerbation in the month after treatment due to the release of the preformed hormone. Patients with large goiters, severe thyrotoxicosis, ischemic heart disease, heart failure, or arrhythmia are recommended to use thiamide pre-treatment until they are euthyroid before radioiodine therapy. Radioiodine therapy is contraindicated in pregnancy and lactation and relatively contraindicated in active inflammatory Graves' ophthalmopathy. Total or partial thyroidectomy is a rapid and effective method of treating thyrotoxicosis. However, it is invasive and expensive and causes permanent hypothyroidism, requiring levothyroxine treatment. It is recommended that patients be pre-treated for euthyroidism before surgery to reduce the risk of worsening thyrotoxicosis and thyroid storm. Complications include hypocalcemia due to hypoparathyroidism, which is usually transient, and vocal cord paresis due to damage to the recurrent laryngeal nerve.